Hey everyone, welcome to Baltimore County Fire Department EMS Academy. For those I haven't met, my name is Sean Barinholtz. I am an anesthesia and ICU physician at Johns Hopkins. I'm a member of Pikesville Volunteer Fire Company. I'm the honor serving as one of the associate medical directors for Baltimore County Fire Department. On behalf of the medical director's office, EMS office, Chief Nats, EMS Training Academy staff, and Captain Lenny Stewart, thank you for what you guys do to help our community every day. And thank you for your dedication to lifelong learning. Big shout out to Ashley Brooks, a young member from Pikesville, who is helping us with our Zoom platform. Later in this presentation, Ashley will send out a link in the chat. Click on the link, enter information, and get your MIM CEUs. If you have any questions about the MIM CEUs or your record or participation, or have any difficulty at all signing in tonight with the link, please hang out with us afterwards, and we're happy to help you get your MIM CEUs. Tonight, super excited to have back with us again, Dr. Laura Bontempo. Dr. Bontempo is an associate professor of emergency medicine at the University of Maryland School of Medicine. She received her medical degree from Northwestern University in '94 and subsequently completed an emergency medicine residency at Northwestern Memorial Hospital. She spent 5 years at Harvard University as the associate emergency medicine program director, and then was recruited to Yale University to become the emergency medicine program director, a position she held for 7 years. Dr. Bontempo completed a master's of education degree with a concentration in health professional education at the University of Illinois. She has received training awards in emergency medicine from Harvard, Yale, Northwestern University, and the University of Maryland. She received a national teaching award from both the American Academy of Emergency Medicine and American College of Emergency Physicians. Dr. Bontempo is published in multiple emergency medicine textbooks and journals and has lectured nationally in the areas of cardiology and otolaryngology. Dr. Bontempo, thank you for being with us. We super appreciate you.
Hi, everybody. Thank you for that introduction. I appreciate that. I'm going to share my screen here. Let's see what we got going here. All right, everybody see that okay?
Looks great.
Hang on, doesn't look great yet. There, hopefully that looks great. Good? Okay. All right.
Yep, perfect.
Hang on. Sorry, always the technical stuff getting your slide shared. Okay. Well, hi, everybody. As you heard, I'm Laura Bontempo from the University of Maryland. And last time I talked to not this exact group, but pre-hospital providers about this talk was pre this thing called COVID, and we were all in person, and it was actually a lot of fun. I really enjoyed it. And now we're back, but on the screens instead. So I'm sorry we can't be with each other in person. I completely welcome you to raise your hands, unmute your mic, jump in with a comment or a question, share a story, because I really think that's how we learn best, by hearing about each other's experiences. Sean has been kind enough to say he would monitor for hand raises and the chat box and things like that. So honestly, really do jump in. I'd love to hear from you. So tracheostomy, critical tracheostomy disasters. Oh, is this going to work? There we go. So first thing to know is that in the United States, we do a lot of tracheostomies. They're greater than 100,000 a year, and most of them go absolutely fine, and there's no problem whatsoever. Only about 1% of them have catastrophic events. Probably about 40% have some sort of complication, but usually pretty minor stuff, self-resolving issues. A lot of them we don't even know about. But 1% have those bad events, and of that 1%, about half are going to die. And these people come to the hospital, there's no question about it. About 70,000 visits to the emergency department for trach complications. And about a third of those patients end up getting admitted. And there's a 1.5% mortality, people dying from these things. So if you're a gambling person, you might say, the odds are I'm not going to see this in my career. And you probably are right. But when you get that patient with a tracheostomy emergency, the statistics don't matter. It just matters that that patient is in front of you. And also, because I assume everyone here works in or around the Baltimore area, you are in the catchment area of two very active academic ENT departments, University of Maryland and Johns Hopkins. So your chances of seeing ENT complications, tracheostomy complications, is actually higher. We see a lot of patients from really far away or very complicated patients within our area that have trachs and tracheostomy complications, because we're sort of a draw for that with these two departments. So why would we do this to someone? Why would we put a hole into someone's neck? All right. First question, right? And usually it's for upper airway obstruction. Someone had trauma, someone had tumor, and the trauma can be upper airway obstruction or a trauma and need for prolonged ventilation, right? Control of secretions. If someone has a traumatic traumatic brain injury and they can't control the secretions or aspirating all the time, well, you have them put a hole in their neck, put a balloon in there to stop the secretions from getting down into their lungs. As I said, prolonged ventilation, patients with traumatic brain injury, recovering from trauma, even if it's not traumatic brain injury, and the patients with COPD who just need a little help with their ventilation. And then there are the kids, anatomic abnormalities, tracheomalacia, generally kids where they don't have that full structure of their tracheal rings and the airway just collapses on itself, and a little bit of extra structure added in there until their trachea can fully form. That's mostly a child issue. All right. So that being said, what are we doing here? What are we doing putting these tubes into people? Tracheostomy is an extra tube into the neck, an extra hole into the airway. We're going to talk about this a few times over to really drive this point home. Normally, you're breathing through your nose, breathing through your mouth, air is going down your trach. What we're doing with tracheostomy is coming in right here and putting an extra hole into the tube, not changing the position of your trachea, putting an extra hole in there, and then putting a device in there, a tracheostomy tube. Tracheostomy tube can be uncuffed, it can be cuffed. Okay, so it can be a balloon or non-balloon. Both are perfectly viable options depending on the needs of the patient. Here's a key thing to know, a key take-home point. Again, going to go over this a couple times to really drive it home. Laryngectomy patients are different. Now, the good news is that laryngectomy patients rarely have complications from their laryngectomy. Okay, so when you see patients with a hole in their neck that have a complication, overwhelmingly, it's going to be a tracheostomy. But here's a really important thing to know. When you are breathing through your mouth, your air is coming down and traveling down your trachea. And if you have a tracheostomy, again, we're putting an extra hole. If you look on the right side of the screen, when you have a laryngectomy, there's a cut. This airway is cut and pulled out to the front of the neck. There's no extra hole. We have reworked the anatomy, and there is absolutely no connection between the nose and the mouth and the trachea, and hence the lungs. Hard stop, no connection. And that's really important when you think about your treatment options for what you're going to do so in pre-hospital. So again, side by side here, tracheostomy is a detour. There's an extra on-ramp, an extra entrance into the airway. Laryngectomy, no connection between up here and down here as far as airway goes. Okay, your nose and your mouth do not connect to your trachea. Okay, so what do we put in these holes? Well, tracheostomies need a tracheostomy tube. They need a tracheostomy tube. They need something to stent that area open because these will actually close slowly on their own. And you may know someone, or you probably have taken care of someone with a prior tracheostomy. You don't sew it, you just take it out and let it slowly close over time. So something has to stay in there. Laryngectomy, patients can have what's called a Lary tube, which is sort of more for their comfort of the area, because you can put a hydration valve on the end of it to pull in some moisture from the air, but they don't have to have anything in that hole. So if a patient has a laryngectomy and something falls out, no crisis, no big deal. That big thing is not going to close on its own. Doesn't happen. Tracheostomy is a different issue. And again, if you have any questions about differentiating these or anything, just raise your hand, throw a question in the chat box, unmute your mic, jump on in. Completely fine by me. Okay. So now I know we're on Zoom, but I want you to commit to your answer here. You're going to tell me if you think the patients I'm going to show you have a tracheostomy or a laryngectomy. All right. Be honest with yourself. Answer. And I'll, of course, let you know. Is this a laryngectomy or a tracheostomy? Okay, that is a laryngectomy. It's a large hole and there's nothing in it. That is a...
These guys will chime up in the chat. You just need to give them a minute to warm up.
Okay, all right.
They will do it.
Okay, I have faith. That's a
they
tracheostomy. Again, I don't see the chat box right now, so if there are questions, let me know. Tracheostomy, there's something in it. It's a much smaller hole. Kids, well, here's the easy part about kids. Kids don't get laryngectomies because kids don't smoke, right? Laryngectomies are primarily done for head and neck cancer. Head and neck cancer, main cause is tobacco. Kids just do not get laryngectomies. If you see something in the neck of a kid, almost no chance of a laryngectomy, almost 100% that it's going to be a tracheostomy. Can you see that behind my box here? It's a kid, right? So
Yeah,
that
we
kid's
can
going to
see.
have a trach. This lady, she's awfully happy about it, isn't she? She has a laryngectomy, right? Again, you see that much larger hole down there, and that's covered by a hydration valve. So she can pull in moisture from the air and keep the area moist. Kid, tracheostomy, right? Kids get trachs. He's also happy about it too. And finally, well, that one, save the hardest one for last, right? That kind of looks, you can't really see the size of the hole there. And there's a strap around the neck. So it looks like what's there is supposed to stay there. But this is actually a laryngectomy patient. And again, when you see that sort of tan color valve, I know it's a laryngectomy, but I'm going to tell you why, if you're not sure, it's important. But if you know the right steps and you get it wrong, you're going to assume that everybody has a tracheostomy and not a laryngectomy. And we're going to discuss why it's important and why it's not as critical if you're not sure, to be able to differentiate one versus the other. Bottom line, if you're not sure, assume it's a tracheostomy. That's the take-home point. All right. Well, thank you for playing along with that. And so I'm going to talk about what can go wrong, right? Lots of things can go wrong with tracheostomies. I mean, my goodness, we're rerouting how you breathe, for goodness sakes. And generally, these are divided into three categories. Things that are intraoperative, not really relevant to you or to me, are early postoperative, and then late postoperative. So obviously, we're going to worry about the early postoperative and late postoperative. Early postoperative, just delayed enough for the patient to get home, have a problem, activate 911 to bring them back to the hospital because they're having a problem. As far as the immediate, the intraoperative, again, not so important for us, but just for your entertainment, I want you to look at the fifth most common intraoperative complication: fire. Right? One of the most common things that can happen in the operating room is you set your patient on fire. And that made no sense to me. You know, we're using ether. What are we doing here? So I talked to one of the ENT residents. I said, yeah, well, you have someone on high oxygen levels because you want to pre-oxygenate them because you're dealing with their airway. If something goes wrong, you want to have that cushion there. And then you're bovying. You're cutting in with a bovie. And if a bovie spark hits the oxygen, you have an intraoperative fire. So apparently it's a fairly common thing. So besides for entertainment purposes, we don't have to worry about that. We're going to talk about the relevant to you in the pre-hospital setting, intermediate and late complications. And specifically, we're going to talk about the killer complications, the ones that you don't have time to look up, that when you get that call and you get on scene and you see that patient, you've got to know what to do because there's very little time to think. Decannulation, the tracheostomy has fallen out. Obstruction, the tracheostomy is blocked. So essentially, a patient is choking. And hemorrhage, that patient is bleeding. We're going to take this one at a time. And hopefully, by the time we're done here, you'll feel much more confident. And trachs, I don't know if trachs scare anybody out there. We're going to learn about these things. And once you learn about these, hopefully trachs will be a lot less scary. Trachs used to make me really nervous too. And now I understand the principles behind them and really honed down on these three major killers that I need to know about. They're a lot less scary for me, and hopefully they will be for you as well. All right. So first, decannulation. Does that mean? It means the tracheostomy tube has fallen out. First thing you're going to do when you get a call for someone in respiratory distress, when you get on scene, you do, right? You put them on oxygen. That's kind of basic. You put someone on oxygen. But remember, there are two entrances to the airway now with someone with a tracheostomy. So when you put your non-rebreather here and your oxygen over their nose and mouth as you normally would, but also put it down here, put it over the trach, right? Get that oxygen in. You're not sure what's working and what's not working at this point. Put a double setup. If you have a fancy trach collar, good for you. If you don't have a fancy trach collar, just take another non-rebreather, turn it sideways over the neck and put it down here. So you're going to have a dual oxygen setup, nose and mouth and tracheostomy. Now, the really important thing to know is, remember, if someone has a laryngectomy, they're not getting any oxygen from up here. But what's the worst that happens if you guessed wrong and you put a double oxygen setup? They get some extra oxygen. Their face gets, the face looks good. They get nice and pink from the hyperoxygenation. Who cares? Put a double setup on. Much better that way than guessing wrong and only putting oxygen up here, having someone actually have a laryngectomy and them getting no oxygen whatsoever. Their nose and mouth gets nice and oxygenated and nothing gets to their lungs. So always err on the side of the double setup. Oxygen, nose and mouth, oxygen through the trach, over the stoma. All right. And then you got to move on these. Believe it or not, within several hours, that size of that tracheostomy stoma will actually get smaller. Now, you're not going to like watch it close in front of your eyes, but over the course of about 12 hours, that thing can actually narrow down. So every little bit of time that passes is much more difficult to get a new tube in. And you may say, well, who in the world would wait for that amount of time after their tracheostomy fell out to get help? Well, you all work in a pre-hospital setting. You know, people make bad choices. But besides people making bad choices, what if someone went to bed, I don't know, 8 hours ago? Say they're like a normal adult and sleep 8 hours at night. I know none of you guys do, but let's say that one of your patients does. Trach falls out slightly after they fall asleep. They're still breathing okay. 8 hours passes with that trach out. They get up in the morning. They realize it. They're still feeling okay. They alert their family. They call the doctor. And you can see how multiple hours can go past. That trach may be out for several hours by the time the patient actually gets to you, by the time you actually get to the patient. Okay. First question to ask, any tracheostomy emergency, the first thing you want to know when you get to that patient is, how old is this trach? How long have you had it? If the trach is greater than just 1 week old, right? Just 1 week, it's considered to be a mature tract. And this is generally when patients go home from the hospital. For those first 7 days, it's such a high risk time that patients, even well patients, are in the hospital for that first week for watching. So your first question is, how long have you had this? If someone says more than a week, which is what you're going to hear most of the time, your life just got easier. Their life just got safer. You're going to gently suction the stoma, right? There's not going to be anything there. So you're going to gently suction, a soft tip suction, if you have it. And then you're going to put it back in. Not a lot of extra thinking has to go on with that, except for knowing what to put back in. And that's a key thing. If someone has an extra tracheostomy tube at home, put it back in. You can throw some lubricant on the outside of it. That's not a big deal. If someone does not, or if it's been out so long that the tracheostomy no longer fits in the hole, which is quite the real possibility, you can grab an endotracheal tube. Now, when you grab the endotracheal tube, I know you guys know how to intubate. You're not putting into 26 centimeters, right? You're going to put it in about 3 or 4 centimeters, depending on the thickness of the patient, right? The soft tissue of the patient, shall we say. You're not putting it in very far at all. And you kind of have this big endotracheal tube flopping out of the neck. Well, you have to make sure that you secure that the best way that you can. You can always cut down the endotracheal tube, but of course you don't want to cut through the pilot balloon mechanism, because then you won't be able to inflate the balloon. So get something back in that hole. And if you can only get something that fits, it's maybe a little too small, that's okay. Get something in there. That's really important. Okay. Now, to make your lives a little bit more challenging, there's no standard measurements for tracheostomy tubes. It is just really confusing. Working towards trying to do that. But if you look at this is a picture of a Blue Select tracheostomy tube. I have no stock in the company. I swear this is just one that I grabbed. If you look, this is called a 7.0 tracheostomy tube. It means that the inner diameter, the ID, is 7 millimeters, but the outer diameter is 3.5 millimeters. It's 10.5 millimeters, 3.5 millimeters larger. Well, 3.5 millimeters in life isn't that big of a deal, but when you're talking about an airway, that's a pretty big deal, right? If you wouldn't grab an 8.0 endotracheal tube for someone who needs a 5.0 endotracheal tube, that's a big difference, right? If the patient does not happen to have the box, of course they're not going to have the box, there's also information on the tracheostomy tube itself. If you look down in this area, you guys see that? I'm not sure if the chat box is covering it or not. You can see that it actually has the inner diameter listed and the outer diameter listed. The inner diameter is 7.6 millimeters and the outer diameter is 12 point something millimeters. It's partially covered on my screen, but you can see that there's no 7.6 tracheostomy tube. It is just confusing. It is challenging, and the difference between the inner diameter and the outer diameter is different from one brand to the other brand, and also that's really hard to see. You're in a crisis situation, someone's not breathing well, I dare you, and this is a clean tracheostomy tube. I dare you to try and read that on a tube that's old, and maybe this is partially worn off. So it is confusing. And it's so confusing that this is what we have posted in our airway supply area at the University of Maryland Emergency Department. If this, then that kind of thing between the two most common brands of tracheostomies that are out there. I have absolutely no delusions that you're going to remember that, right? That would make no sense. Again, these are high acuity, low occurrence events. You're not going to remember this. It'd be silly for you to expect yourselves to remember this. So here's the bottom line. Oops. Endotracheal tubes are measured by their inner diameter. When you have a patient whose tracheostomy falls out, grab the same size endotracheal tube and grab one full size smaller, right? Don't go half sizes here, go one full size smaller. If you notice for endotracheal tubes, the delta, the difference between the inner diameter and the outer diameter is less than 3 millimeters. On the other ones, it was 3 millimeters or higher. So we're talking about a game of inches or a game of millimeters, so to speak, but you don't want to put too much force. You don't want to force something in. Someone tells you they have a 7.0 tracheostomy tube, grab a 7.0, grab a 6.0 endotracheal tube. If you're hitting resistance with a 7.0 endotracheal tube, stop. Just stop and go for the smaller one. It's much more important that you get something in there, even if your patient isn't comfortable breathing through the smaller diameter tube. You got the tube in, right? And then you can bag. You can do assisted ventilation through the new either tracheostomy tube or through the endotracheal tube that you put in. Now, this is a mannequin, and to me, this guy looks scared. This guy still looks scared, and he's a mannequin. So I can imagine what the patient's going to feel like, what the patient's going to look like. It's not super comfortable, especially if the patient is early in their tracheostomy. They're not used to having the tracheostomy change in and out. It's a very anxiety-provoking situation for the patient and for the family as well. It will no longer be an anxiety-provoking situation for you because you will know what to do. Now, that being said, if you get something in there and it's uncomfortable and it's too small and it's not the right size, but it's in there and the stoma is not going to close and your patient can be ventilated, they can be uncomfortable. I don't want patients to be uncomfortable, but they can be uncomfortable. You'll get them alive to the hospital, more controlled situation where we have fiber optics. We can take out the smaller endotracheal tube or the smaller tracheostomy tube and size it on up. They can complain, but they're not going to die. You're doing the right thing for the patient. No doubt about that. All right. Any questions about that? That's good. Okay. All right. Now, what if you replace the tube and you start bagging the patient and they start expanding and they get crunchy under here, right? Well, what has happened? If that happens, and you can see the arrows there, that's all the subcutaneous air, then as opposed to replacing your tube here, you've probably replaced your tube here, right? Probably gotten a false track and you are now bagging the soft tissue of the neck. You're not actually bagging the lungs in through the trachea into the lungs. If that happens, you're going to pull that tracheostomy out and try again. You're not going to harm your patient by retrying and getting into the trachea the second time. If you can't get in, if there's too much crepitance of their neck, sometimes you'll see patients and the crepitance will actually, their whole face will get swollen, like all the way up to their eyes. So really get quite swollen on you. If you cannot get your tube back in adequately, or you try again and you're still causing crepitance, then you can bag that patient and not get something back into that stoma. Not the goal, but if that's what is necessary to keep the patient breathing, to keep the patient alive, so we can get a fiber optic scope into the tracheostomy, so be it. Again, stepwise approach, basic principles.
Bag from above, right?
Bag from above or bag to the stoma. You can bag to the stoma. You can try either one. If you get good air movement, you get good air movement. You still can, right? You just, if you're creating a false track, then you're only bagging into the sub-Q. You're not pushing any air into the trachea. If you can get a good seal, and I'll show you how to do that, and you can push air into that stoma and you get air movement in the lungs, you're fine. Even if the crepitance gets worse, you're still going to keep that patient alive until you can get them to definitive care in the emergency department. Good question. Now, if you're having a really unlucky day, really unlucky shift, and that stoma is less than 1 week old, here's where it gets really dicey, right? Now, most of these patients, you will have a low chance of seeing these patients because most people stay in the hospital until that tracheostomy stoma has matured at 1 week. But sometimes people go home earlier. It does happen. And if that happens, this is where you can get into trouble. It's a really dicey situation because the stoma tract isn't mature. The trachea isn't yet adhered to the skin. It's not stuck there yet. And you can't put something in blind because the risk is if you put it in blind, you can actually not knock that trachea off from its adherence to the skin. And then if you have someone who has any amount of body mass up here, any amount of adipose, that trachea has fallen back and now you're looking for a hole blindly. And the chance of getting something into the trachea, it would be dumb luck if you did, because the chance of you being able to make that connection is very, very low. If that tracheostomy is less than 1 week old, do not reinsert something. Leave it alone. Now, what do you do if your patient's in distress? Well, what would you do if you couldn't get an endotracheal tube into someone and they needed assisted respirations? You would bag them, correct? And that's what you're going to do. Now, bagging someone with a tracheostomy is a bit different. So here we go. You can bag through the stoma. That is completely fine. No matter what the age of the stoma is, you can bag through the stoma. That is a pediatric bag, actually that's a pediatric LMA. If you have those fit very well there, or just a pediatric mask. Either one is fine. If you have to bag someone through their nose and mouth, because remember, tracheostomy, there still is a connection. It might not be a great one if someone has a big old tumor in the back of their mouth, but there still is a connection. You bag up here, you blow air in here, there's a hole out here, or you're going to create as a circuit, right? You're going to get the air blown back on you as you're leaning over that patient. So you have to occlude down here, right? If you're going to bag the nose and mouth, partner, you're with your third hand. I know most of you guys, most of you paramedics have 3 hands because somehow you do more than any one human should be able to do. You're going to occlude down here while you're bagging the patient up here. Now, if you're bagging through the stoma and you're getting a lot of flow, like you can feel a lot, you can hear the patient, they can't keep their mouth shut, then actually, contrary to everything you've been taught about taking care of people, you kind of need to cover here. You need to cover the nose and mouth to make sure that air is going down and not coming out. Okay. So yes, if anyone sees you, it's going to look like you're suffocating your patient, but you know what you're doing. You're going to bag through here. You're going to bag through here. So either way, if you cannot get something back into that stoma, or if it's dangerous to try, because it's less than 7 days old, you can bag. Good. All right. And then you got to drive really fast. Because as we know, bagging someone, especially someone with a history of like head and neck cancer, something like that, that can be dicey. It's not a secure airway when they had a secure airway before. So hit those lights and sirens, get the call ahead, let us know what's going on. Well, we, or whatever hospital you get to, should be there ready with a fiber optic scope, ready to make sure that they are in the trachea and can refeed a tube into trachea to ventilate the patient. All right, that is it for decannulation. We're going to move on to obstruction. So here's my best/worst story for obstruction. Anyone recognize that? That's the ambulance box and the very old-fashioned but current, what we have, the double copy where we write down the information that you guys give us. This is at the University of Maryland Emergency Department. Someone's taking a phone call. We get a phone call saying that there is a en route, priority 1, en route from a nursing home, gentleman with respiratory distress, 80-something years old. I forget the exact age, satting 78% on their arrival, history of head and neck cancer, tracheostomy in place, ventilation being assisted via the trach, being bagged through the trach. Vital signs otherwise look okay, a little tachycardic, a little hypertensive, as you might imagine in this stressful situation, driving to us. By the time, and in the ETA was just minutes, as you would expect in the city, very fast ETAs. By the time they get to us, CPR is in progress. So we're waiting for this sort of airway respiratory distress emergency, and the patient arrested en route, right? And they tell us that en route, his SATs dropped, trying to assist ventilation, can't get those SATs up. Gentleman goes from being tachycardic to being bradycardic, and then loses his pulse. And there they are on a doorstep. So the question is, what happened? And here I am going to pause for a minute and see if I can get to the chat box and give me any thoughts about what might have happened with this patient. Anybody? Or unmute your mic. I'm cool with that too.
Mucus plug, somebody says.
Mucus plug, right? Mucus plug. Okay. Absolute possibility. Anybody else? Okay,
Bleeding.
the one brave soul, Ben.
Bleeding.
Ben, thank you, Ben, for being the brave soul. I appreciate that. All right, and here and Ben is absolutely correct with an asterisk. So yes, a mucus plug, that is absolutely correct. But what happened? I'm going to click back on here. Is that the patient was being bagged through the trach, right? The paramedics did not recognize that although they were bagging, they weren't moving any air. And so they were bagging up against a hard stop blocked area. Yes, mucus plug. And when the patient gets to the emergency department, you can, I mean, I know you guys have all been there, assisted us with it, with these codes. You can see their stuff on the floor. You can see the people. And this is what we pulled out from the patient. We pulled out the tracheostomy, and that is completely blocked, right? And here's another view of it end on. There's no air getting through that. And if you look carefully down here at the bottom, you can see that the ambu bag is still, you kind of get a sense, right, where my fingers are. The ambu bag is still attached to that inner cannula of the tracheostomy. So only oxygen was applied here. There was not a double set of oxygen. So when the patient was breathing on their own, they weren't getting any supplemental oxygen whatsoever. It was only attempting to go through here, which was pushing up against a completely blocked tracheostomy tube. The patient had a respiratory arrest that then led to a cardiac arrest. These are unfamiliar events, right? No blame whatsoever. This can happen to anybody. And here you can get a better sense that the ambu bag is still hooked onto the bottom of that tracheostomy. But if you're not moving air, right? If you're bagging and you're like, yes, I have a definitive airway and the airway is not working, you have to think about alternative approaches, right? Okay. All right. So what happens with obstruction? Well, obstruction can be gradual. It can be people just not taking care of their trach. It builds up slowly over time, or it can be an acute obstruction, such as a mucus plug, which is what likely happened to this gentleman. I think that was more of an acute event for him. What blocks the tube? It's junk and yuck. That's the technical term, right? So you can just have secretions that build up and people just don't take care of it. This is on the bottom left of your screen. That's the tracheostomy tube. This is that same tracheostomy tube cut in half. You can see the dried secretions. That's referred to as a cast within the tracheostomy tube. And the image on the right is much more of an acute. You can kind of see fresher looking, wet looking, and acute obstruction. All right. Also, the tube can block itself. How's that? It doesn't have to be a mucus plug or anything along those lines. Tracheostomy tube can actually position itself so that the back part of the tube is against the back wall of the trachea. So the tube may look like it's perfectly well cared for and you're still not moving air. Think about an obstruction within the trachea. So what do? Well, first thing you do, if someone's having respiratory distress with a tracheostomy, you take everything off that they have covering that tracheostomy. Now, that might not seem like a big deal, but there are all sorts of items out there that you can buy. That's a hydration valve. That's pretty standard. You'll see that a lot. But then there's all these things you can buy on Amazon, which are fashionable tracheostomy covers. And there's also jewelry, right? It's kind of phenomenal. Jewelry you wear on your neck with that hole in the center that should allow air to pass through. But take all that stuff off. If it's that simple, that's what's blocking the tracheostomy tube, you're a hero. Congratulations. You just made the patient breathe a whole lot better. Then again, double oxygen setup, nose and mouth over the stoma. Excuse me, right? Both sides, get oxygen into that patient in respiratory distress any way that you can. And then the next thing you need to determine is that patient have a single cannula tracheostomy or a double cannula tracheostomy. Single cannula tracheostomy is just this firm plastic piece and the obturator, the piece that goes in only for changing it. Should never actually be in there. Obviously, this is solid. You're not breathing through a solid piece of plastic. On the double cannula, there is the outer part of the tracheostomy, and there's this inner sort of straw piece that fits in there. If you're here and the tube is obstruction, this pops out. That inner cannula pops out very easily, and that's going to relieve almost all of the obstructions, right? You're essentially taking the block straw out, and the outer part of that tracheostomy, the outer cannula, is staying right where it was. Patients breathe a lot better. they love you. You've relieved their respiratory distress in a matter of seconds. Now, it's easy when the tracheostomy is out of the patient to know if it's single or double, but what do you do when you're only seeing the outside part of it? Well, you can see on the left, this is solid here, and on the right, you have these two butterfly wings. You have this sort of clear plastic and these butterfly wings. Kids will only have single cannula because the extra cannula adds more space, and there's not a lot of space in those tracheas and those little necks. So they're going to have single cannula, excuse me, tracheostomies. Most adults will have a double cannula just because it's safer. It's much safer to have a double cannula. Again, you can pop out that inner cannula. You can clean it. If it gets obstructed, you can just take it out altogether. And you'll recognize it by having those butterfly wings on the bottom. The newer tracheostomy, double cannula tracheostomy tubes are different than the old ones. It used to be that when you took out the inner cannula, you could not hook an ambu bag up to that outer cannula. When this inner cannula was gone, you couldn't mechanically connect an ambu bag to it. The newer tracheostomy tubes are designed so even when that inner cannula comes out, the outer cannula has the connection, so you can still bag someone to the outer cannula. It's a very nice advance in the design of these tracheostomy tubes because you can take out the inner cannula. If you've relieved the obstruction, relieved the problem, then you can still assist your patient's ventilation without having to find a new inner cannula. Okay. So stepwise approach. If you have a single cannula, you're going to suction. You're going to see what's in there. You're going to put soft suction in there. Try and get out anything that's in there that's blocking it. A kid, it could be a foreign body for all you know, it could be a mucus plug. If it's a double cannula, well, then take out the inner cannula. Squeeze, feel free to squeeze that, take it out. And if worse thing happens, if the whole tracheostomy comes out, that's okay, right? You might not have meant to do it. You might be sitting there holding the thing going, oh my goodness, but that's all right. If the whole thing comes out, that's still okay. But if you can take out the inner cannula only, take that out. Easier. Most of the time you've relieved the problem right there. You've averted the emergency. You've saved the patient's life. Then if you need to assist ventilation. And if the patient needs sort of closer monitoring, you can put them on capnometry. Now we're going to put the capnometry here. No, you're going to put the capnometry down here because this is where you're looking to see if the patient has air exchange. So put your capno down here, watch the patient, watch their sat, watch your capnometry. You'll get a sense of air exchange. And then you can get the patient to the hospital for definitive care.
Somebody asked a question, are
Sure.
casts in the tubing typically resolved with regular suction?
No, they do not. They absolutely do not because they're hard, they're casted, they're crusted. So if they're in the inner cannula, you take the inner cannula out, you've taken the inner cannula and the cast out, and the outer cannula should be completely patent. With kids, it's harder with a single cannula, and that's what we're going to talk about right now. Okay, so if you can't pass your suction, or if you don't relieve the obstruction by passing your suction, then remember we said how that tracheostomy can be blocked by actually the structure of the trachea. It can come against the back wall of the trachea. So give the thing a little wiggle. Advance it by 2 millimeters, take it out by 2 millimeters, just 2-3 millimeters, just move it around a little bit. So if that back opening of the tracheostomy is up against the posterior tracheal wall, you've repositioned it enough that you either have relieved the obstruction, or you can now pass a suction catheter and know that it's patent, know that your patient is able to breathe better. And then you ventilate and capnometry. But if you can't, right, that's what we talk about repositioning. But if you can't, right? So now we're going step by step. First thing you did is say, can I suction out? Can I suction out the problem? Yes, great, problem solved. Is there an inner cannula? I take the inner cannula out. Great, problem solved. Okay, I can't suction. I can't pass my suction catheter. I took the inner cannula out. For some reason, there's still a problem. Unlikely, but still a problem. I'm going to reposition. Okay, still a problem. Then the next thing you're going to do, if it's a cuffed tracheostomy, is you're going to deflate the cuff. Now, why would we deflate the cuff, make a definitive airway less definitive in a patient who's in respiratory distress? Well, follow me here. This is the tracheostomy, but it's blocked, right? There's no air exchange. So there's nothing coming through the tracheostomy, and the balloon is blocking the native airway. So now I'm going to move my chat box here so we can see. I have deflated the balloon that's still blocked, but now there's airflow around the tracheostomy tube, right? This is the patient breathing on their own. You're not assisting this, or you can bag valve mask the nose and mouth. That's completely fine too. If you're bag valve masking the nose and mouth and there's a blocked obstructed tracheostomy and an inflated balloon, you're not going to get any significant air around that tracheostomy tube. That makes sense? So you're going to deflate the cuff. All right. If that still, and then if that works, great. You ventilate, assist ventilation as needed, and monitor with capnometry. If that still doesn't work, right? So now we're going step by step. Here's where you have to have faith that you know what you're doing, because you're going to take that tracheostomy out. Now, does that take some real faith in yourself, some real guts to pull out the definitive airway in someone in respiratory distress? Yeah, it does. But if the tracheostomy is the problem, if the tracheostomy is what's killing your patient, then the tracheostomy's got to go. And remember, if that tracheostomy is more than just 7 days old, that tract is mature enough that something new can be put into that tract and be put in without direct visualization. So remove the balloon is deflated at this point. You've already tried to deflate the balloon and see if you can ventilate around the tracheostomy. If that's not working, you're going to take that tracheostomy out. You're going to suction the stoma, because then there's probably still some mucus in the stoma. Apply oxygen here, oxygen up here, ventilate, as we said before, bag valve mask through the stoma. And you can always think about putting something back in the patient. If you're not getting a good seal, you're not getting adequate airflow, put that same size endotracheal tube or a size smaller in and ventilate through the endotracheal tube. Remember, when you're bagging the person, you're going to bag like this or like this. All right. You're either going to cover the stoma and bag through the mouth, or ventilate, bag directly over the stoma. Make sense? Stepwise approach, algorithmic, step, then step, then step. When you don't do something often, to have these basic principles about why you're doing what you're doing, I find to be pretty helpful. The residents hear me say all the time, if you understand, you don't have to memorize, right? So if you understand the steps, okay, tracheostomy is not working, I got to try and relieve the obstruction. Okay, still not working, I got to work around the tracheostomy. I want to unobstruct the airway, trying to ventilate around it. Okay, that's still not working. I got to get the damn thing out. Step by step by step. Okay, any other questions about that? All right. If all else fails and you cannot get something back in that stoma, you cannot adequately ventilate the patient by bag valve mask, you cannot re-intubate the stoma for whatever reason it is, then the patient does need to be intubated. Now, you all intubate, or most of you intubate pre-hospital. It's not an easy thing to do. I tried to do it once, and I came out with some scraped up knees, and the patient came out with a supraglottic airway, because it's a whole different skill set than when I intubate people at the right height with good lighting and suction and all of that stuff. So I have mad respect for you being able to intubate people in the hospital. This is what you think it's going to look like. And in reality, this is what it's going to look like, right? Because these are not going to be easy intubations. It's going to be quite challenging. But again, this is your 4 or 5 steps into your algorithm here. And this is if all else fails, if you cannot otherwise ventilate the patient, this is what you're going to try and do. All right. Stepwise, important. The part I want to drive home, because I think the part that's probably is going to be the most nerve-wracking, is the point that if the tracheostomy tube is the problem, then the tracheostomy tube must be removed. Will you kill someone by taking the tracheostomy out? No, you will not, because you can bag them. You can re-intubate that stoma, again, if it's longer than just 1 week old, which is why that's the first question you're going to ask. How long have you had this thing? Take it out. The tracheostomy tube is the problem. Remove the tracheostomy tube, support the ventilation, re-intubate with the endotracheal tube if you need to, get the patient to the hospital, there's a fiber optic scope, and hand it off to those providers in a much more controlled situation. You've done your due diligence. You've relieved the crisis right there. You've gotten the patient to the hospital alive. Any questions about obstruction, or anyone wish to unmute and share the experiences that they've had with patients with either decannulations or obstructions? Because I know there are a lot of people on this chat, and I know there have to be some of you, probably multiple of you out there, that have had issues with this. I see some popped up in the chat box. I'm going to peek. Nope. Okay. Nobody? No one's willing to share their story?
So Laura, I'll share, you presented when we were back in person at Pikesville in 2019 ballpark.
Mm-hmm.
Sometime during the COVID pandemic, and a non-COVID patient, I was in the hospital, and we were up on one of the oncology floors, and it was an RRT, or rapid response call, for a patient who was desaturating. And when we showed up, there wasn't a lot of things at the bedside. There's no easy suction available. There's an oxygen port on the wall, but it takes time to mobilize that equipment. And I swear I remember you saying, if the tracheostomy tube is the problem, the trach must come out. And we took it out.
Oh, that makes me so happy.
Right?
That makes me very happy.
That was
And
years
how'd the
ago,
patient
but
do?
I remember that.
How'd the patient do?
Fine.
Good. And
Yeah, they
that's
just
the
had
bottom line. Does it take some guts to do that? Even you
some
as an
mucus in there.
experienced?
Yeah, no, it's never fun.
Yeah, taking
No, it's
it feels quite wrong to take the airway out of someone who's in respiratory distress.
Yeah.
So it takes a lot of guts to do that, but when it's the right thing to do, that's what's going to save the patient's life. Okay. All right, anybody else? Because if an obstruction clears and the patient's clinically improving, is there still a need to transport? If you take out that inner cannula and the obstruction clears itself, you can actually wash the inner cannula. If the patient has a new inner cannula, you can put that in, but it's perfectly fine to literally wash the thing, dry it. Obviously, you don't want to put water into the airway, put it back in. Patient looks okay. They don't want to be transported. There actually is no need to be transported because you've taken care of the problem. If the tracheostomy is out, that's a different thing. Then you got to get the patient to the hospital. And if someone's tracheostomy comes out and you're able to put it back in and the patient's breathing fine, and there's no crepitance in the neck and everything, they can swallow okay, everything seems to be okay. Again, you don't have to transport that patient either. Okay. All right. Some of these things can be dealt with pre-hospital. I'm talking to you about obviously those and also going farther down the algorithm when things go wrong. Okay, but
There is
excellent.
another question. If a child has removed her trach tube but can breathe adequately, should a replacement be placed? And I feel like we've said a couple of times, yes, absolutely.
As long as it's greater than 7 days old. And again, those kids are going to be in the hospital. I don't think any kid's going home before the tracheostomy tube is mature, right?
Right, but I
Parents,
guess I'm reading it as, should we transport the patient? They're breathing and oxygenating fine, transport them, or should we replace it on the scene?
right now, replace it on the scene, put it
Yeah,
back in. And parents do that, right? Parents routinely change their kids' trachs at home. It's part of home trach care. And when it's new, or if there's, say, a grandparent who's watching the kid for a couple hours, or the parents do something and it falls out, they can, obviously, it's a very scary thing to have all of a sudden the tracheostomy come out. But if you're on scene, you get that back in, kid looks okay, SAT's okay, lungs sound like there's good air movement, the child does not have to be transported to the hospital. Exactly correct. Right?
Do patients,
Mhm.
another one, do patients with trachs follow up regularly with ENT, or is there another specialty involved?
Both, usually, for whatever reason they had the trach put in the first place. Like kids, often it's tracheomalacia, so they're going to see ENT mostly, but it would really depend. They follow the ENT and then whatever caused them to get the trach in the first place. Same with adults, right?
Yeah,
They
our
may-
hospital would be ENT or general surgery.
Right, or trauma. If they have a trach because they had multi-trauma and are recovering from the trauma, they may follow up with trauma. So ENT plus, or ENT alone, or ENT plus whatever the other pathology is that made them get their tube in the first place. Okay.
So there's another question, is any of that addressed in the Maryland protocols? And then
Matt jumped in and said yes, and gave some 12, 10 and 12, 11. Thank you, Matt. I would not have known those numbers, not even close. So thank you for jumping in with that.
yeah, it's airway management, tracheostomy change, airway management, trach suctioning are the two protocols that Matt's referring to.
Yeah.
Thanks
And
for
again,
that.
I'm obviously you have to follow whatever your protocols are for wherever you work, but is it mandatory that these patients have an emergency after you fix them? No. If you fix the emergency, you fix the emergency. And a lot of these things will be able to be handled by you. And you can see where something that you can fix by pulling out an inner cannula, if you don't know what you're doing, or if the patient doesn't get help, that same thing can kill the patient. So you go from something where you fix it, they stay home, versus it's not addressed, not fixed, the patient dies from airway obstruction. So your interventions really do make a huge difference for these individuals. All right. And our last topic here, is hemorrhage. Oh, sorry. Can you see that on your screen? It does this to me all the time. Sorry. Okay. Last topic is hemorrhage. This is something which hopefully you won't come across too often, but when you do, it's really, really important to know what you're doing here with these patients. Okay. All right. So when someone is bleeding out of their tracheostomy, you just need to be aware. You need to realize that even if the patient looks okay, this is potentially a fatal event that you're going to and that you're going to try and prevent. Just beware, all tracheostomy bleeding. Okay. First thing, back to the basics, right? You get there for blood from the airway. Well, you're going to put the patient on oxygen, right? You're going to do the double setup with oxygen, get them oxygenated, because if this goes bad and the patient needs definitive airway, not the tracheostomy, you want all the pre-oxygenation on board that you can get. You want to give yourself the maximum amount of time. Just going to check the chat box here real quick. Okay. And then this is what you worry about, right? You worry about a tracheonominate artery fistula. Is most tracheostomy bleeding from this? No, most tracheostomy bleeding is not. But this is a thing that will kill your patient, sometimes with warning, sometimes with no warning. Why does this happen? A tracheonominate artery fistula. Well, back to a little bit of anatomy. There's your trachea, right? And your main stem bronchi, your larynx is up top. And the aorta sits right in front of it. And the innominate artery, which is here, crosses right in front of the trachea. Kind of a design flaw, if you ask me, but funny, no one asked me when they were designing this. So this is how we are, right? That innominate artery crosses right in front of the trachea. And if that innominate artery is a little high, for tracheostomy goes in a little bit low, then it can be a setup for disaster. Why? Well, that balloon's in there and can cause just a little bit of pressure, just a little bit of pressure on those tracheal rings, which causes just a little bit of pressure on the posterior wall of that innominate artery. And pressure necrosis happens. And then when your innominate artery, which is a branch, a first level branch of your aorta, connects to your airway, well, that's not a good thing, right? The bleeding is massive, not subtle. Okay. So again, you can see where that innominate artery crosses right in front of the tracheal rings. And if the balloon's in there, it can cause a problem. This is massive arterial hemoptysis. This is not subtle. Most commonly happens in the second week after tracheostomy is placed, and most of them are going to happen in the first 3 weeks. So again, patients are often in the hospital for that first week, but then they go home. They may go to their regular home, they may go to a rehab, but they're generally not in the hospital for those second and third weeks, excuse me, when you're at highest risk. Now, that being said, these can also happen at any time, and there are case reports of these happening years after tracheostomies have been placed, but the most of them are going to happen in those first critical few weeks after the tracheostomy is placed. Greater than 90% of these patients are going to die. Greater than 90% are not going to survive this. So why am I telling you about this if almost everyone dies from it? Well, 2 reasons. One, not everyone dies from it. If you know what you're doing, you may be able to save that patient's life. The other thing is that 50% of these bleeds have a sentinel bleed. They have a bleed that stops. So there was blood and it stopped. Patients get attention because there was bleeding. And then maybe you show up, they call you and they go, I just panicked. I've only had this thing for 2 weeks. There was some blood, but it stopped. I'm fine. I don't want to go to the hospital, right? Do everything in your power to get that patient to the hospital. I know you guys do. When you think someone needs to go, you call us, we try and talk. You talk to the patient, we try and talk to the patient. This is 50% of these patients have a sentinel bleed. 50% of them get a warning shot before the big bleed comes. So even if the patient looks good, even if the bleeding is stopped, even if their vital signs are perfect, those patients need to come to the emergency department. They absolutely need to know that this is a harbinger of a tracheonominate artery fistula bleed. This is a patient who came into the emergency, it's not a patient, I'm sorry. This is from a patient who came into the emergency department. What we pulled out is tracheostomy. He came in with hemoptysis through his tracheostomy. The bottom part is obviously part of a new device that we're going to put in there. But the top one, not so new, you can see. And we find out what's going on. He gets triaged. The guy looks great. His vital signs are great. The bleeding has stopped. And we all go running in the room. And he can't talk, right? Because his tube's out. He has no ability to pass air through his vocal cords. And we walk, and his patient's going, mouthing, calm down, calm, like, because he's like, why are these people getting so excited? And he's literally telling us to be like, you guys just need to chill out. We're like, we are not chilling out. You have no idea. Like, get in that bed. Let's get an IV into you. But he felt great, and he thought that we're all crazy for overreacting. And we're like, nope, not crazy, not overreacting. We don't want you to die. Please let us take care of you. And he did. But I remember him being like, you people just got to relax. We're like, nope, not relaxing. This is way too dangerous. All right. So all tracheostomy bleed must have the source clearly identified. Now, they're not all from tracheostomy artery fistulus, thank God, right? But you need to look and find the source of the tracheostomy artery. Sorry, not the source of the tracheostomy artery, but you need the source of the bleed. Maybe it's skin bleeding. Someone needs to maybe go down and look with a fiber optic scope and find the source of it, or it's a CTA. Now, obviously, you're not doing this pre-hospital, but the bottom line is if someone says, what are they going to do if the bleeding stops? Well, we're going to look in more than one way to really determine where that bleeding is coming from. And if we can't find the source of the bleeding, then we're going to admit you to the hospital and just keep an eye on you to see if we can figure it out, right? But we really are going to do our very best to look for the source of that bleeding. And this is what we're looking for. Again, I know not what you're going to see pre-hospital, but that where those arrows are. So the eye is the innominate artery. The bottom across the bottom is the aorta, right? That's the aorta, is the innominate artery coming up. This here is the trachea, and this one little bridge, that damn little thing that looks like not much on the imaging here, is what connects this high volume, high pressure system to this essentially no pressure system, and your blood's just going to dump into that. So what do you do? Now you know what we worry about. What are you going to do? If you're in the situation pre-hospital, what you're going to do is you're going to compress, right? When something's bleeding, we hold pressure. That's what we do. Kind of hard to hold pressure here, but I'm going to show you how you're going to try and do it. And then you're going to press, you're going to resuscitate, obviously fluids. Now you guys have blood on the ambulances, so you can get some blood going, and you're going to call ahead so that you any advance warning you can give so that resources can be mobilized at your receiving facility, please do. And if you just say, I have a patient with a tracheostomy bleed, hopefully that will make all sorts of alarm bells go off in the provider who's getting your call, and they'll be able to act very quickly and meet you with what's needed right at the door when you show up to the hospital. So then you're going to drive really fast. All right. So back to step one, compress. Well, you're going to compress here, right? Not phenomenal, but you're going to try and compress that innominate artery. If you do it to yourselves, it's not comfortable, right? You're literally pressing back on your trachea. It's not a great feeling, and your patient's not going to love it either. But you're going to try and compress between your fingers and the trachea, the innominate artery. That may or may not work. Your next go-to maneuver, your absolute go-to maneuver, is to inflate the cuff, if there is a cuffed tube in there, to its maximum volume. How much you normally inflate an endotracheal tube to? How much air do you put in an endotracheal tube or tracheostomy tube? 10 milliliters, right? 10 cc's of air, generally what they're going to hold. They can hold a lot more. And there's your putting your pressure there. And the idea is, let's take that balloon that caused the problem in the first place and now use it to our advantage. We're going to overinflate it so that balloon stands, changes shape, causes more pressure on the anterior wall of that trachea, and can potentially compress and tampen out the bleed for the innominate artery. Okay, so this is what a tracheostomy tube looks like with 10 cc's in it. And I have one here, right? You guys see that? Tracheostomy tube with an uninflated balloon. And I'm going to take my 10 cc syringe. I'm going to hook it on the end here. I'm going to put it up here so you can see. And oops, it's ghosting a little bit. And there's the regular amount that's in there, 10 cc's, right? That's what caused the problem in the first place. I can inflate that balloon by a lot more, right? I'm putting in another 10 cc's. You can see the balloon getting big. You can see it changing shape, still holding it, no problem. I'm going to put in, so I'm at 20 now. I'm going to put in another 10 cc's, right? You can see the balloon still inflating, and the balloon can actually hold up to 50 cc's. And when you do, you can see how the diameter of the balloon changes and the shape of the balloon changes. And that will stop your bleed in 85% of the cases. So for hemorrhage from the tracheostomy, the number one go-to thing, along with your resuscitative measures, is to compress by overinflating the balloon, if a balloon happens to be present, right? There might not be a balloon present, but if it is, use the balloon to your advantage. If it is uncuffed, again, now this patient is bleeding from their airway and they have an airway in, you've got to take the tube out. You've got to get something in there that has a balloon. So as long as it's greater than 7 days old, you're going to take that tracheostomy out. Does that take guts to do it? Yes, it does. Takes guts to do it. The patient's bleeding. They have an airway. No one likes having a blood in the airway without having a definitive airway in, but you've got the chance of saving that patient's life to take that tube out and to get something in with a cuff. So intubate that stoma with an endotracheal tube and then overinflate that cuff. Do the exact same thing. And again, you're only putting it in a few centimeters. Put it in the stoma. That's what an endotracheal tube looks like with a balloon with 10 cc's in it. That's what an endotracheal tube looks like with a balloon with 50 cc's in it. You see how much bigger that is? And again, you don't have to put in the mandatory 50, but inflate until you get the bleeding either stopped or adequately controlled. When you have good tamponade, stop inflating, drive really fast, give us warning ahead of time, get that patient to the hospital. All right. If all else fails, then you're going to try and intubate. So you did that, not working. You're going to try and intubate orally if you can't get something in here, and again, overinflate the balloon. If you can get a definitive airway in, and the patient is still bleeding, and they are bleeding till they're going to die, there's one maneuver left in your toolbox, and it truly is a heroic maneuver, and I truly hope that none of you ever have to do it. It's something called the Utley maneuver, where you literally are putting your finger into that patient's airway and compressing. I'm going to move so I can make sure you guys can see this, but you're putting your index finger into the stoma, your thumb's on the outside by the sternum, and you're squeezing between the two. The one on the bottom, I certainly suggest that you wear a glove, but that was one I found on social media, posted by that doctor. The same principle, there's an endotracheal tube in there, so the patient's airway is not blocked, and you're going to go in and literally try and squeeze that nominate artery forward against the sternum. Hopefully you never have to do that. I have found that on average, when I talk about this, about every 250 people, someone sticks their hand up and say that they've done it once. They've seen a tracheonominate artery fistula once. I was given this talk to, not this talk, but similar topic, to some respiratory therapist. There was an older experienced, I should say, not older, but experienced respiratory therapist who said that she was, at the patient's bedside. Everyone was there. They had, I guess, a sentinel bleed, and the thing opened up right in front of everyone. She was there. She knew what to do. She literally reached in and did the Utley maneuver and squeezed the innominate artery. And of course, you're going to run the patient to the operating room. She told me it was her first day back to work after having knee surgery. So she told them that she couldn't run, next to the gurney. So they just picked her up, put her right on top of the bloody patient, and wheeled them both down to the operating room while she had her finger in this guy's neck and got him to the operating room. And that's the chance of having the patient survive. So balloon, number one maneuver, overinflate the balloon on the tube. If there's not a balloon on that tube, take it out. Get a tube in there that has a balloon, overinflate that balloon. 85% of the time, you're going to save your patient's life doing that. If that doesn't work, then you actually have to try some manual compression by getting your finger into the stoma and actually compressing that innominate artery. Okay. And then you're going to drive really fast, like really, really fast to the hospital, because this is a minute by minute life or death situation. All right. This is something I also pulled off of social media, posted by, you can see the doctor's name up top, Dr. Myers. And she talks about a patient with a tracheonominate artery fistula. There we go. So pulsatile bleeding from the mouth and trach, 3 pressures, 42 units of blood, tamponaded by overinflating the cuff on the trach. And then she went and got herself a new pair of scrub pants. And I think I would need a new pair of scrub pants too. That she saved the patient's life. Apparently he did very well, but she knew what to do. And that balloon tamponade worked, and massive, massive resuscitation. So it does happen. All right. Any questions? Any experiences you want to share? Has anyone has anyone taken care of a patient with hemorrhage, maybe not massive, but bleeding from the tracheostomy? Have you done any of those transports? No? You ready for them now? I hope. Okay. All right. So in the end, the bottom
There are
line.
some comments rolling in.
Oh.
So Matt said,
Okay.
yes, I have. It was a small bleed.
Small bleed. So either it was a sentinel bleed and you got the patient to the hospital and saved their life when they had their big bleed, or it just was a small bleed that was just watched in the hospital. Right? But you never know which ones of those are going to open up. All right.
Laura,
Bye.
that was great. Thank you so
Wait,
much. for
almost
all
done.
that.
Hang on. I want these take home points. Drive them home for you guys. Okay. Because there's a lot. If it falls out, replace it. Put it back in. As long as it's more than 7 days old, don't delay. Get something back in there. If it's less than 7 days old, don't touch it. Bag the patient. If they need assisted ventilation, get into the hospital. If it's occluded, remove the inner cannula. Gonna fix it most of the time. If the trach if suction, the trach needs to come out, take the trach out. If that's the problem, remove the trach. All trach bleeds must have the source identified. Really a hard stop about that. You know, do everything you can to get that patient to come to the hospital, even if they say that they're feeling fine at that point. Massive hemoptysis, overinflate the balloon 85% of the time. That's going to help you out. Otherwise, compress. And, oh yeah, by the way, just to drive home that point, total laryngectomy patients have no connection between their nose and mouth and the trachea. Have I said that enough? Oxygen's not going to help. And I don't care how skilled everybody on this call is, you cannot intubate that patient. There is no connection. All right, that's it. Thank you to all you for everything that you guys do. You are amazing. That is my email. That is my Twitter. If you have questions, you know, drop me an email. It's completely fine. And Sean has my contact information otherwise. All right, thank you. And anyone, anything they want to share, any questions? I'll hang out for a little bit.
That was excellent. Thank you so much.
You're welcome. Let's see something come up in the chat box.